Next, Nanette Wenger is joined by Dr. C. Michael Gibson, professor at Harvard Medical School in Boston, Massachusetts. They cover, is aspirin a necessary component of DAPT? No, aspirin increases bleeding risk with little benefit. Novel combinations or monotherapy are the future.
Let's start, Dr. Gibson, by talking about the limitations of aspirin as an antiplatelet agent.
Well, first of all, aspirin is a good drug. It's been around quite a while, but it does have some limitations. Obviously, it's associated with gastric erosion and GI bleeding. Prostaglandins protect your stomach lining, and by inhibiting prostaglandin production, it causes gastric irritation and bleeding. That's well known. The other problem is at high doses, because it blocks prostaglandins, which provides some vasodilation. It can be a bit of a vasoconstrictor. So one of the keys to aspirin, if you're going to use it, is to get the dose right. And I think we've come to realize that less is more. Just like every antiplatelet and antithrombin, there's a U-shaped relationship. The optimal dose looks to be down around 75 milligrams. Any less than that and you don't get antithrombotic properties. Any more than that and you start to get bleeding. So less is more, and in trials like Plato, we've seen that when you drop the aspirin dose, you get even better effectiveness of a drug like ticagrelor. Do the thienopyridines really need aspirin? Well, back when people used clopidogrel extensively, there are some non-responders. And thank goodness we had aspirin, because if you were a non-responder, then the aspirin was a Band-Aid for the clopidogrel. There are some people who are non-responders to aspirin, and thank goodness they're on a thienopyridine, because that acts as a Band-Aid for the aspirin. So it's a little bit like that line in the Tom Cruise movie, "You Complete Me." These two together were offsetting some of the hazards or limitations of each other. But with some of the newer thienopyridines, drugs like prasugrel and ticagrelor, they're probably effective on their own without aspirin. And when you do all the sophisticated platelet testing, aspirin doesn't add much.
But what are the hints, if you will, that the thienopyridines might work alone, that they might be effective without the addition of aspirin?
The first hint came with the WOOS study. Not in ACS, but over in the AFib/ACS overlap syndrome, and they took the very brave step of getting rid of aspirin. And in a modest-sized study, 600 patients, everyone knows that the risk of bleeding was reduced, was cut in half from about 40% down to 20%. No surprise there. The big surprise came with the effectiveness results, and taking away aspirin was just as good with respect to stent thrombosis and death. In fact, they were a little better when you took aspirin away. Why is that? Well, when you bleed, if you're a patient, my gosh, I don't know which one of these drugs is causing me to bleed. I don't like the blue one, the green one's too big, the red one, it kind of tastes funny. I think I'm going to stop all three. And when you bleed, you fall off the track of evidence-based medicine. So we've come to an increasing realization that bleeding in and of itself may not be bad, but it's what it does to your compliance with all of evidence-based medicine. So that was a big wake-up call. And now there are some ongoing investigations, first in ACS and AFib, to drop aspirin. 3 trials going on right now, all 3 of them similar design. You use your NOAC.
Let's separate this out, and let's talk about just the patients anticoagulated for atrial fibrillation. What about those?
Well, those, I think you're seeing more and more people dropping the aspirin and going with an oral anticoagulant like warfarin plus a drug like, say, clopidogrel. What we're seeing is some of the drugs like prasugrel and ticagrelor have not been as well tested in these kind of combinations, so you have to really exercise a lot of caution there. With the NOACs, by the way, I added up all the combinations of all these different thienopyridines, aspirin, and anticoagulants, different durations, 1 month, 3 months, 6 months. There were 2.5 million different permutations. And we only have the WOOS study to guide us. There's 30 little observational studies. We really
So
need
you
these
need-
randomized
you need a
trials.
trial.
We really need these randomized trials to help guide us. If I had one message for your audience today, be very, very, very careful with full doses of NOACs, with aspirin, and particularly with prasugrel and ticagrelor. You will have bleeding. And I think what these trials are going to help us define is what's the right kind of dose of those NOACs. It probably will be a reduced dose along with these other drugs. There's a trial of rivaroxaban. I'm leading that one. 3 strategies, a Woost-like strategy where we drop the aspirin and use Riva at a 15 milligram dose along with clopidogrel or ticagrelor or prasugrel. Then there's what I call an Atlas-like dose, a trial I'd led where we give baby doses of Riva, 2.5 milligrams twice a day, along with aspirin plus the thienopyridine. Triple therapy, but baby doses of the anticoagulant. And then traditional triple therapy, warfarin, aspirin, and a thienopyridine. That trial we hope to present later this year at AHA. Another trial looks at dabigatran. You have 2 doses of dabigatran, and that will be combined with a thienopyridine, get rid of aspirin. By the way, very important to note, Nanette, in all these trials, you give that first dose of aspirin. You always get that first dose of aspirin, 325.
As they enter the emergency.
As they
room.
non-enteric coated, you want it to get it absorbed, get it fully on board. We're talking chronically here. So this redual trial is using dabigatran with thienopyridine versus warfarin and triple therapy. And then there's another new trial called Augustus, which will look at apixaban and will then randomize people to apixaban or no apixaban in the same size setting. So we've got 3 ongoing trials there. That's AFib and ACS. But in the ACS side,
That's a very separate area.
There's a global leader study that is comparing your traditional DAPT with aspirin and ticagrelor to ticagrelor monotherapy. Drop aspirin pretty early on there. That's very exciting. 17,000 patients, big study. There's another study called Twilight, which gives 3 months of DAPT, aspirin plus ticagrelor. After 3 months, though, you drop the aspirin in one arm or continue the DAPT in the other arm. And finally, a trial that I'm leading along with Magnus Ullman called Gemini, where we're randomizing people. Once you pick your thienopyridine, you can pick whatever you want, clopidogrel or ticagrelor, but then we randomize you to aspirin or rivaroxaban, and we'll see which one of those 2, when added to a thienopyridine, is better. It's an exciting time, trying to get the right dose, the right drugs to the right patients.
Well, we have easily 3 years before we get even the first of those reports coming out. You are the clinician. You are facing the patient across the desk in the office. What do you do for your patient with atrial fibrillation first?
Right. Well, we'll have the results of Pioneer, actually, believe it or not, in AHA of this year.
Oh, really?
So
Okay.
that's soon. So we'll have some information to guide us. Right now, though, personally, I still use warfarin. I use reduced dose warfarin to get just above 2. I try and get people off dual antiplatelet therapy if they have a stent as soon as possible. I try and put in a newer generation of stent that allows me to get them off those drugs by, say, 3 months. So minimize the duration of triple therapy, get them on to warfarin, either warfarin with some aspirin for a while or warfarin plus clopidogrel for a while, then on warfarin permanently.
And of course, we now have all of the new guidelines that have just appeared on the duration of dual antiplatelet therapy.
Less
for
is more,
everyone.
shorter is more.
Well, the fascinating part about it, and I think this is what people mean when they talk about lifelong learning, is what we were doing as standard 2 years ago is outdated, and a year ago may be outdated by the time we get the next major trials reported. Any final words of wisdom for our listeners?
Again, be careful with full doses of those new NOACs with aspirin and the thienopyridines. You're going to have to be very thoughtful. You're going to have to cut the dose back a bit if you're using that combination to make sure you don't have excess bleeding. Be very careful.
This is about as good an update as we have, as of the spring of 2016. Thank you, Dr. Gibson.
Thank you.